靚醫生咧就係阿陳可望醫生啦。陳可望醫生我係土生土長喺 QE 嘅 Associate Consultant。今次講嘅題目係咩話 ？Bone and renal metabolism。
大家好，我其實準備咗係用英文 present 嘅，因為啲 slide 都比較多，所以我都希望30分鐘順利完成到。Good afternoon, senior. Today the topic I'm going to present is bone and minimal metabolism in renal failure. And this is the lecture outline. I'm going to talk is about the impact of CKD on mortality and the mechanism leading to secondary hyperparathyroidism in CKD, and also the biochemical alteration in early CKD, and the impact of hyperphosphatemia, and also the impact of this management. And I also will talk about the KDOQ and KDIGO guideline on the CKD minimal bone disease. And end-stage renal failure carry significant risk of cardiovascular mortality. This is the study by Foley and his colleagues showing that patients with end-stage renal disease, even after stratified for their age, sex, and also race, and those patients who have who are on dialysis carry the significant risk of mortality compared with the same ages who did not have end-stage renal failure. The effect is much more markedly elevated, especially for those patients at a younger age. Apart from the increased mortality, cardiovascular mortality, actually CKD also increased risk of hospitalization and cardiovascular event and all-cause mortality when the serum creatinine was dropped below the GFR dropped below 60 ml per minute. And you will also notice that there is a non-linear relationship between all these events with the GFR. And when the GFR is dropped less than 45 ml per minute, actually the risks of all those events are significantly increased rapidly. And concerning the mechanism leading to secondary hyperparathyroidism in CKD, it is a complex mechanism. When the kidney failed, there's a retention of phosphate leading to hyperphosphatemia and also decrease the hypocalcemia and also decrease the vitamin D, the calcitriol, and all of these were leading to increase the synthesis and also the release of PTH from the parathyroid gland. And at the same time, there is an elevation of the fibroblast growth factor 23, which will downregulate the 25-hydroxylate, and which will lead to further decrease the vitamin D, the calcitriol in the circulation, and this will act as an additional drive for the secondary hyperparathyroidism. Also, at the early stage of the hyperparathyroidism, there is a variable downregulation of the calcium-sensing receptor and also the vitamin D receptor of the parathyroid gland, and therefore they will decrease the response of the parathyroid cells to the calcium and also the vitamin D, and this will lead to the parathyroid gland proliferation and eventually leading to parathyroid gland hyperplasia. Concerning the biochemical alteration in early CKD, this is a study by Levine and his colleague in 2007, and you will notice that the calcium level, the serum calcium, which is shown as a orange line, and also the phosphate is shown as a green line, it will remain relatively stable until the GFR dropped below 20 ml per minute. However, for the PTH, you will notice that the PTH started to rise when the serum creatinine, the GFR was dropped below 60 ml per minute. This is another study. The left axis is show the 24-hour phosphate excretions, and when the kidney disease advanced, there is a gradual reduction of the 24-hour phosphate excretions by the kidney, and it was started to drop when at the stage of CKD stage 2. At the same time, the serum phosphate, which is shown at the right side of the axis, it shows that the serum phosphate will gradually increase when the kidney failed. And it is started to rise when at the CKD stage 3. And you see that there is the urine phosphate excretion decrease before you can see the rise in serum phosphate. So what are the impact of the hyperphosphatemia? And you can see that the mortality actually increased when the phosphate level rise, even within the normal range as defined by the KDOQI guideline, 3.5 to 5.5 milligram per deciliter. And also in this study, they showed that every 0.5 milligram per deciliter increase in serum phosphate is associated increase in mortality in those patients who are not yet on dialysis. And also statistically significant increase in mortality was noted when the serum phosphate level greater than 3.5 milligram per deciliter. And so hyperphosphatemia, apart from increased the mortality, and they also increase the risk of cardiovascular event on patients who are not yet on dialysis. This study showed that for every 1 milligram per deciliter increase in serum phosphate has associated increase of 35% increased risk of acute myocardial infarctions, and also 28% increased risk of death as non-fatal myocardial infarction. And how about hyperphosphatemia in patients who are on dialysis? This is a retrospective study in more than 40,000 patients and who are on hemodialysis. With the reference to the serum phosphate 4 to 5, we found that patients with serum phosphate greater than 5 milligram per deciliter is associated increased risk of mortality. And also, another study shows that for the serum phosphate, the baseline serum phosphate greater than 0.6 milligram per deciliter, it was associated increased risk of mortality even after adjustment for malnutrition, inflammation, and cachectic syndrome. And also, hyperphosphatemia is associated with the chronic kidney disease progressions. And the study showing that patients with serum phosphate within the range of 3.3 to 3.8, the risk of chronic kidney progression is the lowest, while the patient with the serum phosphate greater than 4.3 milligram per deciliter, the risk of CKD progression is significantly higher, even after adjustment for multiple potential confounder. And the hyperphosphatemia promotes the CKD progression is independent of the ACI treatment. This study was carried out in more than 300 patients with proteinuria nephropathy, and they found that patients with a higher serum phosphate level in the quanta 4 and 3 is associated with increased risk of progression to end-stage renal failure compared with those patients with a lower serum phosphate level less than 3.4 milligram per deciliter. Also, the same effect is seen that those patients with high phosphate level is also increased risk of doubling of the serum creatinine. And for every 1 milligram increase in serum phosphate is associated with 84% increased risk of progression to end-stage renal disease, and also for every 1 milligram per deciliter increase in serum phosphate is associated with a 66% increased risk of doubling of the serum creatinine, even after adjustment for the gender, systolic blood pressure, and ACI. This is the same study which shows that the ACI for patients who are with low serum phosphate levels, that means less than 3.45 milligram per deciliter, it shows that ACI has a renal protective effect for progression to end-stage renal failure. However, the ACI protective effect actually attenuated when the serum phosphate was greater than 3.45 milligram per deciliter. So, what are the impact of the management of the hyperphosphatemia? This is a study of more than 10,000 patients who are new to dialysis. They are given phosphate binder within the 90 days of the dialysis, and compare with those patients who are not given phosphate binder within the first 90 days of dialysis. They found that those patients who are given phosphate binder, the ones shown in red line, have significantly improved in survival compared to those patients who are not prescribed phosphate binder. The same study just stratified those patients according to their serum phosphate level. It showed that patients with a serum phosphate level greater than 3.7 mg per deciliter, their given phosphate binder have improved the survival in all the patients with high phosphate level. So what are the guidelines saying? Actually, there are two clinical guidelines that published for concerning the treatment of metabolic bone disease in CKD. The first one is the KDOQI guideline, the Kidney Disease Outcome Qualitative Initiative. It has published guideline in 2003. Another guideline is by the KDIGO guideline, the Kidney Disease Improving Global Outcomes. It has published the guideline on the diagnosis, evaluation, prevention, and treatment of CKD metabolic bone disease in 2009. But the definitions by the KDIGO, it is a systemic disorder of minimal and bone metabolism due to CKD manifests by either one of the combination of the following. First, abnormality in calcium, phosphate, PTH, and vitamin D metabolism. And second is the abnormality in bone turnover, minimizations, volume, linear growth, and strength. And third is the vascular and other soft tissue calcifications. And all these abnormalities will contribute to increased risk of cardiovascular disease and also fracture and mortality in patients who have the CKD minimal bone disease. As we know that patients with the chronic kidney disease, there are multiple factors can increase the risk of cardiovascular disease in those patients with CKD. They've been classified as some transitional risk factor, namely hypertension, diabetes, dyslipidemia, advantages. And there are also non-traditional risk factors, for example, elevation of the interleukin-1, interleukin-6, or tumor necrosis factor, elevated advanced glycosylation and product malnutrition, and also abnormality in minimal metabolism through the mechanism of hyperphosphatemia, calcium load, which will increase risk of vascular calcification, and also through secondary hyperparathyroidism. It will increase the risk of cardiovascular disease in patients with CKD, and at the same time, they will also lead to abnormal bone and also will lead to fracture. Concerning the diagnosis of the biochemical abnormality, this is the table try to sum up the KDIGO recommendation. They recommend that monitoring of the biochemical marker of the CKD immune bone disease should be started at the patients with CKD stage 3 onward. And the frequency of monitoring actually depends on the stage of the chronic kidney disease. The more advanced the chronic kidney disease, the more frequent the monitoring. And also, it all depends on the magnitude of abnormality and also the rate of progression of the chronic kidney disease. And in patients who got CKD and already receiving treatment for the mean bone disease, it is reasonable to increase the frequency and to monitor the trend, the treatment efficacy, and the side effect profile. And also, this is the KDOQI guideline recommendation about the target range of the calcium phosphate level. And the one on the up, in black is in the unit of milligram per deciliter, and in our hospital we are using millimole per liter. Therefore, I also provides the reference range here. And those patients with stage 5 disease who are on dialysis, they recommend the phosphate level keep around 1.13 to 1.78, and they did not give specific the absolute range for calcium, but just they suggest keep it within the normal range. And for calcium, for those patients who are on dialysis, they suggest for 2.1 to 2.37, but preferably to keep it towards the lower end of the lab recommended level. And they also suggest to keep the calcium phosphate product within less than 55 milligrams square per deciliter square. And also, the guideline has suggested the total elemental calcium intake both including the dietary calcium intake and also the calcium-based phosphate binder should not exceed 2 grams per day. And this is the KD gold recommended level for the calcium phosphate. Actually, they did not give any absolute reference range. They suggest for those who are not on dialysis, keep it within the normal range, and for those patients who are on dialysis, the phosphate keep it towards the normal range. And this guideline emphasized on individual calcium and phosphate, and they did not, different from the Tokyo guideline, they did not suggest for the treatment for the calcium phosphate product. And so the treatment aims is target at lowering the high serum phosphate and maintain the serum calcium. And apart from advising the patients for low phosphate diet, still the patient may got hyperphosphatemia. So what are the treatment options for the patient? This slide just shows the evolution of different types of phosphate binders that go into the market, starting from 1970, and the aluminium-based phosphate binder, and then the calcium phosphate binder, and then the sirolimus and the lanthanus in 2002. And actually, the choice of phosphate binder depends on the serum calcium phosphate PTH level and the presence of a dynamic bone disease or with or without vascular calcification. For those patients who had a dynamic bone disease or vascular calcification, we are trying to avoid the calcium-containing phosphate binder because they will accelerate vascular calcification. And this table was trying to compare different types of phosphate binder and on the effect of the mortality and also the coronary calcifications. There's some limited studies showing that sirolimus can improve the survival in patients who are on dialysis and also not on dialysis. And also there are trends towards less progression of the coronary calcification with sirolimus. And the lanthanus, they are showing that they have a few episodes of hypercalcemia. And a few words about this sirolimus. This is a cationic polymer. This is a non-absorptible agent containing neither calcium or aluminium. It binds to phosphate is for the ion exchange. And there are two preparations of this drug in the market. One is the sirolimus hydrochloride is called the renal. The second one is the sirolimus biocarbonate with the vanilla. And several randomized control trials show is effective in lowering the phosphate and PTH. And this is the true study showing that sirolimus can improve the survival in patients who are new to dialysis and who are not on dialysis compared with those patients who are taking calcium-based phosphate binder. And how about the treatment of a normal PTH? This is the guideline, the PTH target level as recommended by the two different guidelines. For the Tokyo, they give an absolute reference range for different stage of CKD, and those patients who are on dialysis, they suggest to keep it around 16 to 32 picogram per ml. But for the KD guideline, for those who are not dialysis, when there is a normality of the PTH about upper limit normal, they suggest first evaluate for any hyperphosphatemia, hypocalcemia, and vitamin D deficiency. But those patients who are on dialysis, they suggest to keep it around 2 to 9 about the upper limit of normal. The reason why they do not give an absolute reference range for the PTH because they found that there are significant variations in the PTH result with different laboratory assays. So, how to treat the elevated PTH? Actually, there are numbers of active vitamin D analogs in the market, and in our hospital, we have the alpha-calcitrol, rocaltrol, and the paracalcitrol. I'll give a brief talk about this. The rocaltrol and the alpha-calcitrol is the non-selective vitamin D receptor activator. The rocaltrol is a natural form of active vitamin D produced by human body, and so this is our first treatment of options. And there are studies showing that intermittent high dose versus lower daily dose therapy, they are equally effective to suppress the PTH. For alpha-calcitrol, this is a prohormone of the rocaltrol. It needs to be converted to rocaltrol by the 25-hydroxylate in the liver, and also it is shown to be effective for suppress the PTH and compare with placebo. But so far there is no head-to-head comparison of these two medications. For pericalcitrol, it is a selective vitamin D receptor activator. It is called the second generation vitamin D. It has been shown to potentially have a survival advantages, and that there are the only prospective comparative studies suggested the no significant difference between pericalcitrol and calcitrol. But its advantages is that we're able to suppress the PTH with less severe increase in calcium and phosphate. This is the study that compare with calcitrol and pericalcitrol, and in terms of the primary endpoint, is the PTH dropped by 50% of the baseline, and actually they show that there is no significant difference between the pericalcitrol and calcitrol to reach the primary endpoint, and also there is no significant difference between group to control the calcium phosphate product value. So up to now, we're still facing some problem of resistance. Up to 50% of patients with severe hyperparathyroidism show little or no decline in PTH level with the calcitrol therapy. There are some postulations is that there are large functioning parathyroid gland, or there may be altered the calcium sensitivity of the parathyroid cell, or failure of the hydrovitamin D because of the hypercalcemia and hyperphosphatemia. And so what can we do? There is another drug, is the calcimimetic. It is active allosterically increase the calcium sensing receptor in the parathyroid gland to calcium, and potentially suppress the PTH by the mechanism that complementary and potentially synergistic with the vitamin D analog that target on the vitamin D receptor. And now available drug that in the market is the cinacalcet. So this is the study using the data combined with 3 placebo-controlled trial involving more than 1,000 dialysis patients. You can see that those patients who are on transitional, both groups of patients who are on transitional therapy, namely the vitamin D and on the phosphate binder. But one group is randomized to the cinacalcet, one group is randomized to the placebo. If you can find that those patients who are randomized to the cinacalcet, they are able to control the PTH. This is the gray area is the recommended target level by the K-Dokyo of the PTH, and also the calcium phosphate product, and also the serum phosphate. The cinacalcet group are more patients that are able to reach the target of the recommended K-Dokyo reference level. So the conclusion that patients on dialysis with secondary hyperparathyroidism, cinacalcet facilitate achievement of K-Dokyo recommended target for PTH, calcium phosphate, and the calcium phosphate product. This is another study, and using the combined analysis of the sub-4 similarly designed placebo randomized double-blind trial, also involving more than 1,000 patients, and they found that cinacalcet treatment compared with placebo, they can decrease the need for parathyroidectomy, also decrease the risk of bone fracture, and also cardiovascular hospitalization, but not on mortality. But having said that, the cinacalcet is so useful, but it was not advisable for patients who are not on dialysis. The reasons why is that for those patients who are with CKD stage 3 to 4, cinacalcet actually would decrease the urine phosphate excretions and increase the serum phosphate. But it is different from those patients who are on dialysis. Actually, cinacalcet won't increase the serum phosphate. But while for vitamin D analog, the effect is more consistent across the various stages of CKD. And some special precaution when we prescribe cinacalcet is that we should not start the drug when the serum calcium is less than 2.1 millimole per liter. And also we should be cautious in patients who got seizure, and we need to monitor the calcium level because hypocalcemia may precipitate seizure and also prolonged QT interval. And the most commonly reported side effect of this drug is nausea, vomiting, but you can assure the patient that this sort of side effect actually will be lessened when the drug is taken with food and also resolved with continued use. And but we still got some patients who are severe hyperparathyroidism. We have not respond to medical treatment, so what can we do? The KDIGO guidelines suggest that those patients who are not respond to medical treatment suggest for parathyroidectomy, similar to KDIGO guideline that those patients with severe hyperparathyroidism also associated with hypercalcemia, with or without hyperphosphatemia, where we back to the medical treatment that suggests total or subtotal parathyroidectomy. This is the summary of the therapeutic algorithm of the central hyperparathyroidism in patients with CKD. The main difference of the two latter, those patients on dialysis and those patients on dialysis, is that those patients on dialysis, we actually can, especially those on hemodialysis, we can increase the duration and frequency to removal of the phosphate, and also for those patients on dialysis, we can use silic acid. And come to the take-home message, and CKD patients with minimal bone disease associated with increased risk of cardiovascular disease, fracture, and mortality, and phosphate dysregulation associated with increased risk of cardiovascular event and mortality in patients with CKD. And the mortality of risk increase as the phosphate level rises, even you can, as just mentioned before, even when the patient remains in normal range. And the treatment of phosphate binder in dialysis patients associated with increased significantly improve the survival, and there's no single pharmacological intervention is sufficient to completely restore the disorder and of calcium phosphate homeostasis. And medical treatment of secondary hyperparathyroidism in patients with CKD is mainly involved dietary control, phosphate binder, vitamin D, analog, and also with or without calcium emitting. If all these medication treatments fail, consider parathyroidectomy. And that's the end of my presentation.
講完快，有咩問題咧？比較複雜啊！
How would you like to treat dynamic bone disease you have mentioned? Dynamic bone disease, of course, that you mentioned, the bone turnover is very small. If we talk about the secondary hyperparathyroidism, the bone turnover is very quick, okay? And there's cases which is very small, and then the patient got also Malaysia. It's quite a displacing sort of situation. So how to manage?
Actually, this is quite difficult to manage. And for those patients, we will try for, as just mentioned, to try to avoid using the calcium-based phosphate binder because it will increase the risk of vascular calcifications. And also for those patients, we can use vitamin D analog, but we have to monitoring the calcium because there are increased risk of, if we use high dose, if you have hydro, you will also further suppress the bone turnover and also increase risk of hypercalcemia.
I ask you this because that some of study will show that if there's an aluminum accumulation, it also tend to cause this dynamic bone disease. So is there any study in your percent that about this aluminum toxicity that you look at this?
呢個係歷史嘅問題嚟嘅，即係 aluminum toxicity 咧，就係咧好耐之前咧就 report 過 ，PMH 都有 report 過，但當時咧其實咧最主要原因係因為啲 RO 水，當時嘅 RO 水咧就唔好似而家咁 pure， 咁所以咧啲水喉管咧其實好多 aluminum 嘅嘢喺度，咁所以咧 aluminum toxicity 主要係因為啲水嘅問題。我哋 oral 嗰啲 aluminum 咧，其實咧我哋做過啲 study 咧就做嗰啲公辦時，其實咧係冇好多 aluminum 嘅 L 傻或 L 尺嗰啲，其實咧係唔會引起嗰個 aluminum bone disease， 係唔會係 cause 係大嘅 bone disease， 所以唔係一個擔心嘅地方。
想問下咧，嗰啲粗塊，即係我見到一個病人有糖尿，我相信佢都係有腎嘅問題，咁咧就見到啲粗塊，即係膠質粗塊。咁另外一個咧就有一個好似輸到膠嘅腳痛。咁呢兩個 case 個輸到膠係咪 due to calcium， 都係 due to calcium， 即係喺你嗰個 picture 裏邊係點樣 fit 啊？輸到膠
calcium power， 另外係啊 phosphate 嗰就應該同呢個就未必好係有好大嘅 association 應該。而家嗰個粗化咧，其實就應該將嗰個 uric acid 咧，盡量撳翻低個正常個 level， 等佢可以improve 到個膠質透化。
仲有咩問題咧？可能比較少見啊，睇張圖。如果冇問題咧，咁啊揾下醫生喎。